here we go. Okay, so we're just gonna give it a couple of minutes for people to join. That's what we usually do, and we'll take it from there.
Okay.
Okay. All right, perfect. Okay. Hello, everybody, and welcome to the Everyday Leader Live. So, I'm so excited about today's episode because I have two of my favorite people in the global surgery realm. And they are incredible women who are global surgery leaders in their own paths. And first, I'll introduce my co-host, Dr. Judith Hullner, an AcuCare and laparoscopic surgeon currently practicing in Tanzania. And she is a fellow executive leadership in global surgery and of course, my esteemed guests, my good friend, my teacher, my mentor. She's a lot of things, and I fangirl over her all the time, and she knows it. Professor Salome Maswime, and she is a highly accomplished and internationally recognized leader in the field of global surgery with an impressive body of work, including 91 publications, just a little bit shy from 100. Currently serving as head of global surgery division at University of Cape Town and director of UCT's World Health Organization collaborating Center for Integrated Clinical Care. And her contributions extend to areas like surgical system strengthening, social justice, health equity, and making her pivotal voice in ensuring universal access to quality surgical care. And this is just some of what she does. There's a lot more this lovely young lady does, and she has been an inspiration to, I think, anybody and everybody who's ever crossed their paths with her. And even people who haven't met you, I think, have heard of you, especially in Africa. You are quite an influential voice, and yeah, we are happy, and I'm very honored to have you here on my live. So, welcome.
Thank you so much. I'm very excited to be here, especially to be with both of you. As you said, favorite people in one room. So, really excited to join. Thank you.
Yeah, I think we have upped the game for the next cohorts, the coming cohorts in executive leadership, because they gotta do better than this. So I don't know.
Lots of pressure.
Yeah, yeah. Um, yeah, we are just gonna dive into it if you're okay.
Yeah.
Okay, so Prof, you have had an extraordinary journey. Obviously, medical school, then you are an OBGYN, and
Yeah.
then becoming a leader in global surgery and having all these leadership roles as head of global surgery division and currently as the interim CEO of Health System Trust, which I know is quite an important organization in South African healthcare. And throughout your journey, what has inspired you, especially early on in your career, to get into this path and become such a profound force in global surgery?
Yeah. Thank you very much. So the journey itself, because it was never about accolades and promotion and all of that. It was always about, following my passions and also following my purpose. And also along the way, you get opportunities at first it's not what you had planned you wanted to do with your life, but being responsive to the journey has been one of the things. But also finding myself in a health system that didn't provide what I thought it would provide. You go to medical school, you think you're going to save lives, and then you find yourself in a hospital signing death certificates when you know that some of these lives could have been saved, that these were preventable. And I think more than anything, it was my not being satisfied with the health system and the state of the health system that pushed me to try and find ways of solving the problems. And they say you climb up a mountain, and when you get to the top, you realize there are many more mountains. And so it's literally been that, because I thought, by specializing in obstetrics and gynecology, I'd be able to sort out women's health issues and save more women's lives. Then I realized, no, there were systemic issues, there were global health issues, that some of the solutions were outside of the surgical theater. And so that's really been the journey of saying, how can we make a difference whilst we are alive, and improve healthcare, particularly for Africans and African women.
Yeah, wow. I completely understand because if any healthcare provider, I mean, anywhere, obviously, no system is perfect, right? Every system has inherent flaw, but especially in Africa, our healthcare system just have so much challenge within it. And as a surgeon, yes, you and your scalpel can do so much, right? And then there's the bigger pictures. There's everything that goes on outside of that
Mhm.
four wall
Mhm.
of a theater. So that's very important. And I think people have to keep in mind what you just said, that you need to be flexible because
Mhm.
sometimes your career kind of finds its own way and you
Yes.
don't really need to set yourself as to like, I'm going to be this and then that's it.
Yes. Yeah.
So
Yeah.
and I think the nature of being a problem solver makes
Mm.
you, quite an adventurous person. So you go into every, you go to solve every bit of a challenge, and you discover
For
a
sure.
whole new,
Mm.
potential that you have. So, wow, that is amazing. And I think there's a lot to learn from there. So from your current leadership position, what is the
Mm.
most significant
Mm.
bottleneck that you think is impeding the scale up of safe,
Mm.
affordable, and timely surgical care, especially in underserved regions? And what do you think? What innovations in global surgery do you think can
Yeah.
solve such problems?
Yeah, so we know now that we have to see surgery or access to surgery as a public health issue.
Mhm.
But I think a lot of surgeons are still struggling to see that, if we're going to bring a public health side to global surgery, we also need to apply public health principles. We say access to surgery, and then we want to pick up our scalpels and go back to the surgical theater. And yet, issues around access have largely to do with what kind of programs exist to make surgery accessible to those who need it the most. And if we aren't designing programs to improve access to care, if we aren't working with public health specialists, we aren't working with governments that are designing programs for access and ensuring that surgery is given attention and also included in the surgical care, or in programs, that in public health programs, we are not going to achieve our goals. And think the biggest barrier is that we are trying to solve an access issue
Mm,
through, by applying surgical principles. And until we start thinking about it differently, we will keep finding ourselves trying to do the same, trying to solve the problem without finding the solutions, speaking amongst ourselves as surgeons about solving surgical issues, whereas the people that really require access to surgery themselves don't even know how important access to surgery is.
yeah. Yeah, for sure. I completely agree because you can sit at a well equipped and well staffed referral center in the
Mm,
city, right?
mm,
And you can take pride in treating how many patients per day. But the people who actually really need those interventions are not the ones who come to the referral hospital.
yeah.
They're out there in the rural
Mm,
areas, and they're
mm,
visiting the primary health care centers, and
mm,
at the lowest level. So
mm,
to make a real impact as a surgeon, and to deal with the surgical burden of disease in any
mm,
country and system, we really
yeah.
have to make surgery
Mm,
accessible. So you're
yeah.
right. I think we as surgeons, first of all, need to
Mm,
hang our scrubs maybe a couple of
mm.
days a week, not maybe every
Yes.
day, but
Okay. Yes.
couple of days a week, and go out and do the full work and make sure people who deserve and mostly
Mm,
need that access actually get
mm,
the access to surgery. And I think, I don't know, I mean, Judith, I want to hear your take on this, but I don't know how it is in the global north, since you're a very good representative for that. But
mm,
surgeons are kind of shamed for not doing surgical work, even
mm,
if it has a big impact. People would say, he doesn't like surgery, that's why he's doing this, or she don't like surgery, that's why she's doing this, right? So
mm.
how do we become supportive towards each other to to really actually realize a bigger change? Judith, what do you think?
Yeah, thank you so much, Annie. And so glad to have this discussion here. It's so, yeah, already so powerful, I think. Asking about the global north, so I had to think about it briefly. So it's so interesting. I had to learn about global surgery and access to surgery only after coming to Tanzania, right? And after the leadership course as well. So in the global north, you're not thinking about access to surgery because the access to surgery is there. So you're only needed to go into public health if you're now thinking about administration or policies or something like that. But as a surgeon, you are actually working in pretty well, at least where I worked, in mostly well working systems. So you don't only here now, you're just talking out of like you're talking straight to my heart, thinking about the Tanzanian reality of I need to go out there actually and tell people because we are working in the tertiary care, but actually people don't
Yeah.
reach us. But that's not the same in the global north. And it's interesting, the shaming I have not experienced as much, or actually not at all. It's I guess where I worked, it's rather the other. It's the opposite in a way of like we have a lack of surgeons. So when you actually do surgeries, you get a lot of credit for it, while everyone else will understand if you don't, because the toll on you again is quite high. So everyone is like, oh wow, it's not that many anymore doing it, kind of. So
Yeah.
yeah.
But
Yeah.
I think you also need to allow your career, to evolve to whatever it you ultimately want it to become, because I had to make the difficult choices between, for me, it was leaving the labor ward, at a time in my life where everyone felt like if you just stay a bit longer, you will become a head of department, and you'll be remembered as a renowned obstetrician. And a few months later I was working for a surgical department and outside of the labor ward, and it is scary to make those decisions that I've got a PhD in obstetrics and gynecology, what am I doing in the surgery department? Right now I'm leading a public health organization. It's neither obstetrics, it's neither surgery, but life does allow you to make some of those moves, if it appreciates the skill sets that you bring. And I think we should also allow ourselves to look beyond our peers and colleagues who often, like I said, I did up to a PhD in obstetrics and gynecology. The only people that I knew were obstetricians and gynecologists, and it's hard to break away and try something new when you've defined yourself by the circles that you live in. But when you're driven by purpose and by something greater that says, I can make a difference out there if I allow myself to, it will be easier to make those decisions, and you find new friends in new disciplines, and people do respect you ultimately for the decisions that you've made, even when you've broken away from what they thought you would.
Yeah,
Yeah.
yeah, yeah, yeah. Absolutely.
Can I
Go,
just
go ahead. Yeah.
add to that? Just saying that I think no, I also really understand your question, Annie, is that I think, you know, it's only a few people that break out of that one identity that you get, especially as a surgeon, right, with high status. But following their purpose and passion and knowing something is not quite right and actually leaving this kind of secure environment to go out and maybe be shamed, maybe be insecure or have some financial instabilities, all these things, but actually, you know, you're following your heart and actually you're the ones that might be the change makers, right?
Yeah, exactly. Obviously, I think if anybody does what they're passionate about, they'll be successful. Like I think it's almost impossible for somebody to follow their passion and not be successful. If doing surgery is your pure passion, then you're going to be an excellent surgeon, obviously. But if you have a big personality that cannot be contained in the theater, like you do, because I know you, the two of you personally, and you know, it's you if you have that talent to connect with people, to be able to say something and actually get your message across, because I really think that is a talent in a way, and it's not celebrated enough. And I know you two have it, and so many more of our friends who were in the executive leadership program. It was so amazing to see. For me, my personal experience when I was in that room, I felt so much better because I always kind of felt like an outlier where I used to work, because everybody just wanted to cut open a patient, and that's a great thing, and I admire that for them. But for me, it's like you said, I used to think if there's a challenge for a patient to go from the ward to the theater, whether it's because of lack of blood or lab work or some sort of administrative issues, there's so much that happens, right? When you first encounter a patient to a point where you do surgery and then they're out. So all that for me, I'm very, I have the same attitude. I feel like if there's a problem, you know what, there has to be a way to solve it. I cannot just say this is my job and I just do mine. So I'm not that kind of person. So these are extremely fantastic points, and I think a lot of young surgeons who kind of maybe a bit fearful taking that step towards a kind of a little tweak to their career paths can learn a lot from what you both said. And I think next time, Judith, I think I will be interviewing you because I want to know. There is a question for me that clicked because you said in the global north, you don't worry about access because access is already there. So I wonder how that was achieved. You see, because what was the approach? Because at some point, somebody has said, this cannot be enough, right? Somebody had been where we at the Global South are right now and decided that we need to do better. And that's how they made surgical care accessible to the larger population. So I think it's something to dive deep into, and it will be interesting to see.
Yeah, absolutely.
All right, the floor is yours, Judith.
Thank you. So yes, Prof, I'm so interested in, you know, of course, we are living in a quite disruptive era of a meta crisis with a lot of geopolitical shifts, financial instabilities, and especially impacting global health. And my question, of course, is, and my feeling, and you know, I'm an optimist, and I think something great will come out of this, especially like including Trump, including everything, right? This is also not about Trump. It's like it's definitely something bigger. And I see Africa rise in this. And I wonder, how is Africa going to be able to do it to maybe redefine the foundational values and structures of global health.
Yeah.
And my question is, Africa has long been framed as beneficiary of global health, right? But now it's a powerful source of innovation and leadership.
Mm.
Okay. And the question is, what are the structural and mindset shifts that you think are needed, both from within and outside the continent, to fully realize Africa's leadership potential?
Yeah. So most importantly, we have to own both our problems and our solutions, and so even when I started the global surgery journey, what was unique about it, and I mean, having spent a year overseas, I did my postdoctoral fellowship in Harvard. So my principles of global health, I actually needed to leave the country to learn about them because, no one was really teaching this where I was or in my country. But when I came back to start a global surgery program, what was unique was running an African global surgery program in Africa, meaning that the solutions to our problems are developed right here by us understanding our problems in the context of our problems. And that has been the mindset that I have had, that we need to approach a health system strengthening. We need to have a health system strengthening approach, which takes into consideration our burden of disease, our priorities, the communities that we live in, and the potential solutions that we have, that no one is going to fly out to solve Africa's problems, and the challenges that we've experienced in global health show that, remind us of that if we don't own the problem solving and see partnerships with high income countries as a means to a solution, not as a solution, if we don't change that, we won't ever get there. Who determines our burden of disease, or our priorities? In many countries, we have programs for HIV and AIDS, which is good, which is excellent. I think we've learned a lot from the HIV/AIDS movement. But a lot of these programs were determined by funding that came from high income countries, not always by the fact that this was the leading cause of disease, or that there were other diseases that we needed to pay attention to as well. So I think we need to change how we do global health. That global health is about partnerships, is about sharing resources, but until we own the solutions, we're never going to find the right solutions. And I think for me, I at least try to stand here as a leader that is trying to own the solutions, and to lead solutions, and to come up with innovations that understand the context of where we live, and then seeing all the other partnerships as a means towards achieving the shared goal of improving access to healthcare for all.
Thank you so much. Um, I totally see that, and I totally agree. I think it needs to come from inside, taking on the issues, taking on the problems and the solutions, and it needs to be a power. But what do you think? What is the external part? What needs to change in the mindsets of high income countries? Like
Yeah.
giving the note of decolonizing global health, and that's from the north.
Yes. I mean, I think I'm very concerned right now because, we came out of a time where, everything, global health was fashionable, like, uh, find an African country, find an African partner, find, an African student, and let's share our resources. COVID did show us that, when things got very tense, that, countries could also decide to prioritize themselves, and put a pause on global health, as a concept. But, then we recovered and we continued. And I think what we've seen over the past few months again is countries saying, let's focus on ourselves and let's sort out our own problems for now. And I think that is fine. In principle, I don't have any issues, because in general, as human beings, we'll always focus on ourselves and our families and our local before we go and give. You give out of the extra that you have often, and not out of, yeah, you don't give the minimum that you have. You kind of give out of excess. So it's okay that everyone is rethinking how important is it to have these global health partnerships, and to support countries that are struggling. uh, but we do need to pause and try and understand that global health as a concept is about all of us achieving universal access to health. I like to say that it's a vision. It's not a gift. It's not a donation. It's about what can we all do to ensure that in any part of the world, when you suffer from a certain disease, you are not going to die from that disease unnecessarily. And then our partnerships will be built on strengthening healthcare globally, rather than trying to
Mhm.
achieve power, and trying to see who the next superpower is. So fundamentally, that's what I think. And if we start shifting that, then it's not going to be about where who comes from, but what can we
Mhm.
do together to achieve universal access to healthcare.
Yeah, I really like that. That takes the whole map, redesigns the whole map from there is no high income and low income, right? We think global, and it's actually about strengthening healthcare globally. Yeah, I really
Yeah,
like
Yeah.
I mean,
that.
many
I
many of us have worked in high income countries. We contribute to the health system there as well, but somehow, when we define brain drain, brain gain, all of that, we often assume that global health is someone from a high income country coming to work in a low and middle income country. We don't think about the fact that we share resources and human resources all the time.
Yeah.
There's no high income country where you're not going to find Africans practicing and sharing their own skills and resources, and contributing to the healthcare system there. And so we need to acknowledge that with globalization, we are sharing resources across the world, with regards to healthcare. And when we recognize that, then we can think differently, around how we define these processes and principles.
Yeah.
Yeah,
If I
thank
may
you
add
so much.
something, Judith, I think there's always something to learn from every system, right? The way that the global north has achieved access in their countries, it as a cost of something. Nothing, you don't achieve anything without paying the price. So but in Africa, we have the opposite. We might not have the monetary resource, the financial resource, and what comes along with that, but we have a whole lot more other things when it comes to providing quality healthcare. Because for my patients, instead of them lying down on whatever biodegradable mattress, which I have no problem with, but I'm just saying, instead of that, they would rather have somebody who understands that there is nobody to take care of their 6 kids at home.
Mhm.
Somebody who can relate to that, or they would have to sell their cattle to get treatment, or just so much that goes into caring for patients. Because I think, and I'm sure Prof will agree with me, when you work in an African healthcare setup, you're everything for the patient. You're not just a doctor, you're
Mhm.
their psychologist, you're their social worker, sometimes you're there a financial support, you give money out of your pocket.
Mhm.
So, and I think that is a beautiful thing, and I don't think there's anything wrong. Yes, the fact that we have those problems is heartbreaking, but it also is one of the biggest strengths that I think we have, and it is not celebrated enough. But like I said, both sides can learn a lot from each other, and I think as in the African setup, we have to be careful when we adopt the global north system, because like Prof said, we have to make it tailored to our context, and also we need to make sure we don't lose our strength.
Mm.
Yeah.
Thank you so
Absolutely.
much. Yeah, absolutely. One take on what Prof said just before your beautiful comment. I think, it's not only, or even you said it, Annie. It's like, it's not only on some costs that came that like helped or actually made it real, to be able that high income countries could realize that, right? It's exploitation of the rest of the world, and that needs to be very clear. But that's a clear in our circles, right? But it's not clear, and that's what I'm saying also. That why I loved how you said it's like everyone needs to rethink, and that's what I also want to get out there. It's like, okay, that we have to, the high income countries, to rethink and be clear that it's not on nothing that they have achieved what they have achieved. Yeah.
Mm.
And I would love to take up your point, Annie, on and ask the question. So how could African healthcare leaders now lead the way in designing resilient and people-centered care with the strengths you mentioned? Because I believe they are truly unique strengths.
Yes, yes, yeah. So I always feel, sometimes how we approach health system strengthening is wrong. We come up with the solution before we understand the problem, and we have to understand our problems. We have to understand our own systems. We need to do the research, the evidence that shows us and guides us to say that, okay, this is the highest burden of disease. These are the process issues. These are the structural issues that need to be addressed. Then we start developing context specific solutions. We start to align our budgets with the problems that we want to solve. Because often you find there's a mismatch saying that, okay, we've got problems. We do have money. It's not that the money isn't there, but it's how are we using these budgets that we already have and maximizing on the potential of them, and then determining which are the biggest priorities. And so when we start going into health system strengthening, with an approach of wanting to improve the health system and address the challenges that are unique to the health system, then you'll find that we start having wins and more wins along the way. I think the challenge is that we tend to focus on where the money is coming from and what the money is dictating us to do, and put aside even the most basic things that one would expect a healthcare system to prioritize. Some of the things do not require a lot of money. A dignified healthcare system or a dignified experience in a healthcare setting, that it doesn't require huge investments. It requires that we look after what we have. But so often you walk into hospitals across our African countries where you, even as a healthcare practitioner, you feel like, I'm okay. I would rather not be treated in this space. And then, but when you try to diagnose what is the actual problem, it was cleanliness, cleanliness, access to water, access to electricity, the simple things. And so I think addressing healthcare challenges is a science, and but it's not a very complicated science if we try to strengthen our systems addressing the challenges that are there and obvious to all of us.
Talking about electricity.
I have to find a line. So maybe you continue.
We've lost Judith.
The African
I'll be back.
problems.
I love this. Get a candle, Judith. That's how we do it.
Mm.
Yeah, those are, important points that you mentioned. I think we really need to think about some of the things and see how simple they are. They're just very simple. It's like you said, when you just said it's about cleanliness, I thought of my orthopedic ward, I thought of the theater, I thought of everything. And yes,
Mm.
it's just a mop and a broom.
Mm.
That's
Yeah.
it. And
Yeah.
just wiping down everything. And
Yeah.
maintenance. I think one of the biggest problems that we have in our setups is we get, even with donations, we might get the most advanced whatever equipment, right? The same thing that you would find in the US or in Europe, in any European country. And it works for 3 months, if we're lucky, maybe 3 years, and then it breaks down. And there's nobody who's been trained to fix it. We don't have the parts for it and stuff like that. So that's just a waste of resource. And we go back to asking for donations again to buy it or whatever. So, and we have to also be careful, like you said, who we take donations from, um, because there are just one too many containers with broken equipment that is being sent to ship to Africa. So sometimes, in the name of donations, we receive garbage. We are accepting somebody's garbage. So we really have to be careful. And like you said, when we partner with international partners, we need to really understand what their mission is, what uh, what their focus is, and does it align with our priorities.
Yeah.
And we really have to do our due diligence to research that those partners are legit and they have the best in mind for our population and people, because we are the advocates, we are the bridge, right, between donors and
Mm.
patients. So we have to speak up, we have to do our due diligence to really
Mm.
see through and find the right partners.
Yeah, I mean, I just want to add, I mean, leadership is key, which is one of the reasons I'm so passionate about health leadership and ensuring, because that's where decisions are made,
Yeah.
If you don't invest in the decision makers before they become decision makers, then the decisions that they make, will not always favor the people that they are looking after. And I've said before that, we can export equipment, surgical skills, all of these things, but countries choose their own leaders. Countries will seldom even choose leaders who were not born in that particular country. And so it's important that, the investment in health leadership, because those are the people that will be deciding who do we partner with, what
Mhm.
gifts are we going to accept, and then the question becomes, who's really leading this country?
Yeah.
If the health system is so dependent uh, on international partners, then who's really making the decisions,
Mhm.
and so we need to think about that if we don't strengthen our leadership and how we make decisions and what type of decisions we make for our health systems, then if we don't do that, we set ourselves for failure.
Yeah, for sure. Go ahead, Judith. Can you hear?
Yes.
Okay.
Yeah, yeah. Sorry. Can you see me somehow?
Yeah.
It's
Yes,
okay.
we
You can see
can.
me somehow, right? Um.
Yes.
Yeah. So I think my last question is actually goes also into leadership, of course. And if you could plant one seed in the hearts and minds of Africa's future healthcare leaders, one idea or value or vision to guide them into and with this uncertain future, what would it be?
Mm.
That we can solve our problems. That we don't need to look very far. And
Mm,
that's two levels to say, we don't need to look very far in terms of the human capital that can solve problems, but we don't need to look too far to understanding what problems we actually have to solve. You know, and it's just what you said now about, you know, just looking at your orthopedic ward as a surgeon and thinking, why isn't this clean? You know, why wasn't the floor mopped? Those simple things that remind us every day that we can do better and we can make the system better. You know, I always appreciated, especially the years where I worked close to my own home village. I appreciated the fact that, you know, I was able to contribute to it with the conviction that, you know, if my mom ends up in this hospital, you know, things and the services that are being provided very different than when hospital you don't necessarily you know, like there's
Yeah.
us and then there's them, there's us workers, there's us who can
Mhm.
afford, and then there's them who, you know, populations, but own hometown or your village, the feeling is different. There's no them,
Yeah.
it's us. It's all us. And when we take that mindset to say, in our healthcare facilities and centers and around do to improve healthcare and to improve access to healthcare and to improve the quality of care, you know, over and above that which we get paid to do. I think when we start thinking about that, then we can really start solving the problems and not wait for anyone to come from elsewhere. Elsewhere could be another city or town. It doesn't mean coming across, you know, flying from another country. But let us take responsibility for what we see in our own health systems and try make that difference. The difference isn't going to come, you know, collectively across countries and all of that. It's going to come across villages, cities, towns,
Yeah.
districts. And when we all start getting better, then collectively, then you'll start seeing improvements.
Yeah.
Yeah, really like that. Already, what you said earlier with the local problems or the local issues and the local solutions, right? And then the last thing that you said, I really like the small steps, right? The small steps that come together if we work on what is in front of us, actually, that can make a huge ripple effect. Yeah, I like that. And to
Yeah.
believe in that, right? To believe in that. So that's something I think for me is it's sometimes hard, right? It's sometimes hard to believe that a small step will eventually lead to something bigger. Because if everyone takes a small step, we will get somewhere.
Yes. Yeah.
With,
Yeah.
Yeah. Yeah. I mean, wow, you raised excellent points. Just to piggyback on that question that Judith had, I I always wonder, and I want to hear your thought on this. What about local resource? Like Africa has rich people. Africa have a lot of successful business people and things like that, right? So in the ways in the global north, you see, you know, people create charities and things like that, and they donate to academic institutions or hospitals and things like that. So
Yeah.
and I know you're very well connected, and I'm sure you know a lot of people. So, what has been your experience? What do you hear from those people? Why aren't they the ones investing in our healthcare when it affects them, their mothers, their siblings, you know, and their family down the road?
Yeah. So, I mean, let's a lot of goodwill and a lot of people doing good things and giving and who are trying to make a difference. So I do want to acknowledge that you know not everyone is doing nothing and holding their monies, and also that there are people that are giving of their time, their skills, their expertise. So it's not always going to come in monetary terms, Uh, but then there are also issues around giving, and it's complex because sometimes people have the money but don't trust those who say they go and make a difference, or they don't, because it is ultimately an investment, and so people would rather give to other causes where they perhaps think that that will be better use of and resources. Healthcare is very complex and I think a lot of people feel, that it is a risk,
Mm-hmm.
for them to give, and you never know whether the resources are going to be used properly or not, and also issues of corruption and all of that, so I think it is tricky. I have struggled. I thought when I walked into, sort of this global health world and all of us being committed towards ensuring that more lives are saved, I thought we'll find a lot more African philanthropists giving to healthcare, and that, our solutions will come from there. But that hasn't been my situation. My situation has been, yes, I've been well funded by African organizations, linked to government, etc. But I haven't really seen a lot of generosity in the philanthropic space. There may be many different reasons for that one that we won't always have to speculate about. But I do think that there are opportunities for people to partner with those who are really committed to making a difference. When we look at our finances and you find us, wanting to celebrate being African organizations making a difference in Africa, but your leading funding, constantly coming from high income countries. Questions that you are asking, that, is there something that we're doing wrong? If if
Mm-hmm.
if we say we want to solve our own problems, resources and the giving and the generosity, um, we still have to go outside to look for that, for then we are constantly contradicting ourselves, unfortunately.
Yeah, yeah. I mean, this could be unpopular opinion, but I think you're right. There is something called social entrepreneurship, right? So you can solve socially important um, s- issues, including healthcare service or whatever the people may be interested in, but at the same time get profit out of it. And I have a friend in Ethiopia. He started a paramedic program, and you have to pay to go to the training and everything like that, but we don't have pre-hospital care in Ethiopia, and we never had a paramedic program in Ethiopia. So he did that. He took a leap of faith. Of course, his background was he was from a health background and things like that. So when he actually became successful businessman, he shifted to social entrepreneurship, and he did that, and that has influenced the government to start paramedic training programs at a university level. So there's a lot of impact that people can make if they just take, like you said, that leap of faith and just uh, do a little bit. And also, I think having private institutions, especially in the capital cities where people can actually afford to pay, which means you can take all that financial burden from supporting those big tertiary referral hospitals and things like that, and you can take that money and build a whole lot more rural, primary healthcare setups that could potentially do some sort of surgery, like it might not be advanced surgery, but at least do basic surgery, just like it has been done with maternal and child health. And I think there's a lot the rest of surgical fields can learn from how it was approached to make maternal and child health services available to the large population. Yeah. Oh, those are really good points. Thank you, Judith, for the fantastic questions. Before I continue with my questions, we have the unofficial co-hosts, which are our attendees, and we have questions in our comment section. So I'm gonna shoot a couple of them your way. So Helena Kasahun, that's I think she's MD, and she's a doctor, an Ethiopian doctor. She asked, curious, what are the most urgent issues in global surgery today, especially across low and middle income countries?
Yeah. So I think most importantly, it's the indicators. How are we measuring access to surgical care? Of course, we've got the indicators that were proposed in the Lancet Commission for Global Surgery. 10 years later, many of us are not able to count, perioperative mortality rate, the number of surgeons in countries and all of that. So I think we need to rethink our indicators, because if we don't get the right indicators, we are never going to measure appropriately, and we'll never really know what the real state of surgical care is. And then when it comes to surgical financing, how are we defining it? So if we're defining funding that goes into surgery, all African countries are operating. There is, not as much as we should be, but there is a budget that goes into surgeries being done, and surgeries are happening.
Yeah.
But from a programmatic side, to say, how are we going to increase access to surgery? The funding for that needs to be thought out a bit differently, because that may include quality improvement measures, capacity building, training of surgeons, um, and community engagement, health education, health promotion, prevention strategies. So if gender-based violence, injuries, trauma, cancers, non-communicable diseases, if these are contributing towards preventable surgeries, what are countries doing to prevent these conditions from happening? And so how that is financed will be very different from the clinical budget, so that we can provide clinical services. But yeah, I think there's a lot of things that I think we need to think about very differently if we want to improve access to surgical care. But those are just a few at the top of my mind.
Yeah, yeah, preventable surgeries. That's an excellent term. I love it. I'm gonna use it all the time. And Judith, I'm so happy Power's back.
Yes, she's back.
Yeah, and Helena also asks, what is a book or a code or a piece of advice that shaped your leadership philosophy?
Yeah. Sure, that's I love leadership books. Yeah, all the time. If you catch me, I'm reading a leadership book. I love John C. Maxwell, and
Mm.
just the different principles that are in his books. Yeah, there are books like the 48 Laws of Power. For if you're really asking me about leadership, I think the concept of power has always stood out to me the most, uh, and how you define power. Power obviously looks like, this big, fierce, and mighty, strength that one has to, take over the world. But power is about getting things done. Literally, if when you say, I want you to join a webinar on a Saturday night, and we show up, that is power. And power isn't always forceful, and isn't always power, may be just a few SMSs or WhatsApps that keep reminding you that you said you'll do this. Please show up. But yeah, I bring that up because if leadership is about getting things done,
Mm.
small things as well as big things, it starts off with understanding what power is, and how power is used, and the different forms of power. And so I guess for me, that was one thing that changed my leadership trajectory,
Mm.
understanding that there are different forms of power and different ways of using power so that you can achieve a goal at the end of the day. And there is an art and a science to it as well.
Oh yeah, for sure. I think the world is used to hard, what I call hard power, but soft power is the most powerful power.
Yes. Yes.
I mean, everybody on this live can see Prof's smile. That's $1 million smile. That's how she gets things done. Don't be fooled. Don't be fooled by her smart. She is an extremely intelligent woman, but that smile, that's what seals the deal. Really, you have such a way of making everybody feel special and very welcome. And you, with all your accolades and your success and everything, you are still very down to earth. And I think that is an extremely important thing, to set as an example for young people of what power is. Power don't have to be somebody who is weird with a wall and they have poker face and stuff like that. No, that's not what it is. And this is really what a true example of power and leadership is our queen prof, as I call her. And
Thank you.
we have another comment from Fantan Tareking. He's a PhD anesthesia student. He says, "Good to see Prof. Salome. She's ample of expertise in global surgery and leadership. I know how much you've done. Good leadership with Professor Bruce. I'm sorry, with the African surgical outcome studies. So there are people who are very well familiar with your work already, and he said it's a very interesting research. So
Thank you.
yeah. Okay. Oh, did we lose Judith? Oh my God.
Yes, she disappeared, but hopefully she'll join back.
Reappear. Okay, so let's go on, because I already feel guilty for keeping you busy on a Saturday night. Mhm. So we've been talking about a lot of very personal stuff, very African centered discussion so far, because we are Africans, and this is where we do our magic, and this is where we serve our beautiful, multicultural, just amazing, population that we've been lucky to serve. So, but if you were given the mandate to draft a global surgery 2040 blueprint,
Yeah.
what would be the single most transformative yet achievable policy change you would prioritize to accelerate the equitable access and quality surgical care worldwide?
Yes. So, so there isn't one single solution, but we developed the Global Surgery Action Framework, which is available online, which is really a tool to use to solve access to surgery problems. And I really believe that, that framework gives you a very systematic approach to solving surgical challenges in a very context specific way.
Mm,
And so it's never going to be one policy that you can roll out across the world,
mm,
because our problems are different in different contexts. But if you can teach people how to solve their own unique challenges in a very systematic fashion, then you can start seeing improvements in terms of reducing the burden of disease, improving the quality of care, ensuring that communities are well knowledgeable and educated about both their health systems and their health conditions. So my thing that I would want to be remembered for is for contributing towards an action framework for global surgery, which gives you a very systematic manner, an approach to solving access to surgical care challenges. And
Yeah.
so it will go into policy issues where policy needs to be addressed, but I don't think there's a one
Mm,
size fit all approach. Yeah.
yeah. Yeah, excellent point. I mean, speaking from a place of true um, experience and leadership position, and I think for anybody who don't know that global surgery framework, can you speak about it a little bit so that the
Yeah.
audience can be familiar with it?
Yes. So our action framework essentially has got four steps. The first step is that, when you want to address a global surgery challenge, you need to diagnose, the health system challenge or problem, the sickness of the health system, as I like to put it. Because when patients are sick, we go and diagnose them and then we treat them. When health systems are sick, if they cannot provide access to care, we need to diagnose what the sickness is, what the challenge is, and then we co-design and co-create solutions and interventions. The interventions that we propose are community engagement, quality improvement, capacity building, and policy engagement. And so that's the multi-pronged approach that I was speaking about. That in some instances, yes, you need more surgeons, but in some instances, you need better policies. In other instances, the community, you need to start off with solutions at community level. And then lastly, evaluating the real impact of your solution so that you know whether your interventions have worked or not, and then you can decide whether they can be scaled up or not. But essentially, that's what our global surgery action framework is about.
Yeah. Wow. Yeah, I think, like you said, for a systematic for a problem in a system, you have to have a systematic approach, right? So you just if you just jump from one problem to
Mm.
another, then you'll just end up with new and
Yes,
different problems. That's
yeah.
just it.
Yeah.
So it has to be systematic.
Mhm,
It has to
mhm,
flow. It has to start from the most important priority areas and flow down towards less priority areas and go as such. So, systematic approach. Everybody who's here attending, go and read about this surgical global surgery framework that Professor just mentioned. And I know you're exhausted. One more from the audience. Mulugan asks, should a medical doctor be first accomplished and successful in their clinical practice to succeed and influence in his or her leadership?
yeah, so we need to understand the different competencies, right? If you want to be a very good surgeon, then you need to practice surgery all the time, and being a very good surgeon does not equal being a very good leader. If you want to be a good leader, you have to learn about leadership and develop the competencies of leadership, right? I think the problems that we find ourselves in is you find leaders that are neither good leaders nor good, no good
Mm,
clinicians. And then these become the people that are making decisions about us and our health care. So when I realized that I wanted to become a leader one day, I knew that I needed to practice, yes, on my clinical competencies, but also that there was separate a different type of training that I needed for leadership, and I needed to do both of those concurrently. Leadership is not something that you start in your retire to as you approach your retirement. These days you can be very young and be in a leadership position and be able to influence change. And when you're making decisions, of course, it helps being trusted as a credible clinician. People will, it adds value, when people know that we trust you. But ultimately, a lot of decisions that one has to make as a leader uh, tend to have very little sometimes to do with their clinical competencies, uh, depending on what exactly you're leading. If you're leading if you're a clinical head, you obviously need to be a great clinician, so that you provide the understanding and the role modeling that one would want to see in that setting. But in many leadership spaces in healthcare, the clinical competencies do not necessarily determine how good a leader you will be.
Mm, yeah, yeah. Judith, what do you
Can I,
think?
yeah, can I add to that?
Yeah.
I'm also, of course, very interested in leadership. That's why I attended the course, but also in global strategy. But since then, been on a very journey, definitely to diving into leadership. And I think, as we know from the course as well, right? We are all leaders in what we do, and I think um, talking about leadership sometimes sounds like that sometime in the far future I will be a leader, or that's my goal. But especially, I think as clinicians, we are leaders as soon as we actually reach specialist or consultant level, right? We are leaders, and it makes such a big difference to know something about leadership and how to actually, lead your team. And it can be a team of one, two, three, four. It doesn't matter. And actually, we always are in teams, right? Especially as surgeons, and it makes such a big difference. And my one of my passions or purposes is actually, especially in certain areas of surgery, to change leadership, because it's still sometimes last century than rather this century of leadership. And so I can just encourage everyone to look into leadership as soon as possible, and also to get it into the curriculums. We have it now in Tanzania here where I work, in the curriculum, but there's no one teaching it. So I was talking to Prof. Barnabas, and I will also talk. I mean, we would like to get some faculty together to talk about leadership in the curriculum for the medical students.
Yes.
Yeah, yeah, that is very, very important. There are so many soft skills as medical doctors that we never get trained. We're just trained, make a diagnosis, treat the patient, make sure they're okay. That's it. And but there's so much that goes into making a clinician a well-rounded clinician, right?
Yes.
Uh, so leadership, research, communication skills, all those things, even some basic knowledge of finance is very important, and it will also help us be a good leader once we step into that position. We'll be ready and fit for it. And I have one more question from the audience, and I promise you this is going to be the last one. Uh, Fontaine asked his anesthesist, so I think this is a relevant topic for him. He says, from your studies, I have seen obstetric mother who undergo anesthesia and surgery are 50 times more likely to die compared to high income countries. What are the opportunities in Africa for reducing this?
Yes, yeah. So I mean, the reasons for this, are multi-pronged. This is often a reflection of the health system itself, the poverty, the excess, and then once the women are in the health systems, the hospitals are not able to provide the care that the women need. So we get them to the surgical theater, we do the cesarean section, they bleed. It was a junior doctor, after all, who did that cesarean section. They don't know how to do a hysterectomy, they don't know how to stop the bleeding. By the time you have to refer the patient to another hospital, similar to your situation, as you're saying, if there's no referral systems that are efficient, a patient dies waiting to get to the next level of care. So it really goes back to how we strengthen our health systems, redesign our health systems, ensuring that you've got the right people providing, yeah, able to provide multidisciplinary care. Because in this study, what you're seeing is the outcomes of the sickest patients, so yes, there was the 90% who did well, and everything went right. But for those who had complications, this is the worst outcome. And when we plan for healthcare, we talk about preparedness these days. You have to prepare for how is the system going to rescue those who have the worst outcomes, because that is ultimately going to be the reflection of how good and how bad the system is. When we talk about health systems or good health systems, we don't talk about the number that survived. We talk about mortality, mortality rates, and so that strengthening so that fewer people with complications are dying and having preventable deaths. Most importantly, is how we can start to make a difference. And these are at facility levels. You will understand and know what is it, where are we failing at our facility. But when you look at it across multiple facilities or across a country, and you're able to see our maternal mortality rate from cesarean section in country A versus country B, then you can start coming up with what are the interventions we need to come up with in order to save more lives.
Yeah, thank you. Thank you so much for that answer. I think Fantown will be very satisfied with your response. And like you said, we measure preventable deaths, right? Because I mean, if we just look at the lives we have saved, we might be fooled, thinking that our surgical care systems are actually functional. So yeah, thank you. And my last question for you, really. And you shouldn't have invited me to your house because it's on you that I came up with this. uh, as you know, as a mother of two strong boys and a successful husband in his own field, what do you advise upcoming leaders on how to navigate the work-life compromise, and what resources have you personally helped you do that, and how often do you use your leadership skills from work at home?
Okay, a very packed question, and I'll try unpack it and answer it to the best that I can. I think the first thing that I always acknowledge is, that first of all, I am Salome Maswime. Uh, Before I'm a wife, before I'm a mother, I have my own calling and my own, things that I want to achieve with my own life. And I have to have those honest conversations with myself about what are my dreams, what are my aspirations, what do I want to do with my life. If there was no one else in this world, what would I want to be remembered for, and what would I want to achieve? And I need to be faithful to the purpose and calling of my own life first. But I'm also a mother, and I'm also a wife, and I need to be faithful to those roles as well. And so I think for me it has never been an either or get
Mm.
50% here and 50% there. For my boys, I am everything. I am their world. If I'm not there, or if I'm tuned off of my mothership role, who's going to look after them? And what is the implication of me being an absent mother? Now, I may not always be physically present in my home, and my kids are quite comfortable with that, but they want to know that we've got a mother who is fully attentive to us, who's got our best interest for at heart, and who wakes up and thinks about us before she starts her day. And same with my husband, that It's not enough to just say that, oh, okay, because I'm a good mom, therefore good mom equals good wife. Those are two different roles. You
But I put it
and you
in.
can't substitute one for the other. You have to be a good wife this side, be a good mom this side, and just be a good human being that's fulfilling their purpose on the other side. And I think it's that has been my journey in striving for uh, a balance in doing the most that I can do in those areas, and trying to achieve some sort of excellence across the different areas. And yes, we don't always get it right, and yes, sometimes things suffer, and yes, sometimes you let down, you know, either your colleagues or your husband or your children, but you keep trying and you keep striving and you keep trying to do your best in each one of those roles. And so that has been my philosophy.
Yeah, yeah. I mean, so many gems in there. I mean, I want to get a redo because I just learned a lot of lessons. So I'm like, can I just go back and change that part of my life? Yeah, so many important things. And I think at the end of the day, you really have to be true to yourself. And that is, I think, the most important point from everything you've said. And uh, being true to yourself means being true to who you want to be in each role that you play, right? As a leader, as a friend, as a wife, as a mother, as a daughter, as a sister. I mean, it's just there's so much as a human being that we are different roles that we play. So like you said, we might not be successful in all of them, but if we can just be good enough in all of them, I think that should be the target.
Yes.
Yeah, so I think those are excellent points. But how do you use your leadership skills at home? Do they work at all?
So home is different. At home, I'm not the head of the house, and I'm not the CEO either. And then to my kids, my kids are not seeing all of those roles that the rest of you see. My kids are like, Mommy, I've got a play date. Please sort your life out so that I can go see my friends. I mean, I was away for the weekend. I was traveling. I flew home, got home last night, and one child has gone for a play date. The other one is like, why are you home late? What's going on? You know, today, my husband, he went out, to see some of his friends. I'm thinking, like, I'm here. And I'm here with all the time. This is my family time, and everyone is just going about doing their own thing. It's not let's pause and the CEO has arrived type. Attitude. So it does keep you humble. It keeps you as yourself. It keeps you knowing the roles that you need to play. I do use some of my organizational skills at home, because running a home is also a bit like running an organization. Yesterday afternoon around 1 o'clock, I had to map out who was where and who needed. It didn't work out the way that I had planned anyway, because not
Oh,
everyone read the instructions. But I tried. I tried to say, okay, this child will arrive at this time, and this one will, and then they need to go there, and then this one needs to do this. So, and well, because I try use my organizational skills, it does bring a sense of stability, and I'm able to reduce chaos and plan.
yeah,
This is what we're doing tomorrow, and all of that, because those are my
yeah,
my
yeah,
everyday skills that I use. But yeah, you don't walk into your home wearing the same hat that you were wearing at work. It's a different context altogether, and I do appreciate that. yeah, some things I need to leave at work.
Yeah, beautifully said. Very authentic. I love this so much. I learned so much from what you just said. Just because sometimes, even if you are a stay-at-home mom, life is a chaos, right? There will always be chaos, and especially when you have kids, they just take over your life and just,
Yes.
so I think professional women and women in leadership should not be scared and discouraged to have a family and to be there for their family and also enjoy their careers because nobody has figured it out. That's just the reality. We just we're just making it as we go along, and we should all give ourselves a grace and just enjoy everything we do. Yeah, thank you so much, Prof. I mean, it's always a pleasure. It's always an honor. And I didn't know I had missed you this much because it's been so long since I've seen you. And I'm so happy that I get to see you again. And Judith, same thing. We've kept in touch over the past few months, going back and forth on a couple of ideas. So hopefully we'll all get to do as the executive leadership in global surgery group, we'll get to do one big project that we will be talking about everywhere across Africa and wherever we are. So thank you, Judith, for joining me, for sharing this burden of
Thank you so much. Thank you so much. It was such an inspiring. I feel again like we're back in Cape Town, and I'm held kind of by Prof in our passion and purpose, and being like felt like, okay, we're not the outsiders. It's us together. And it was a, yeah, it gave me actually a lot of energy, which is beautiful. And you're the Prof, you're like the not the spearhead, but really the inspiring force to know what purpose and passion and following it is. And that's really amazing. Thank you so much.
Thank you to you both. I think it's been incredible spending this time with you outside of the classroom, but it's been incredible, and I think just a reunion. And I think all of us should keep trying to make a difference in our spaces. As I always say, no one's going to come and do it for us, and so
Yeah.
let's keep making a difference in the surgical spaces wherever and however we can. And thank you for hosting this and bringing your world into this space, and sharing, all our knowledge and expertise so that others can also see how they can make their world better. Thank you.
Thank you. Thank you, ladies. Enjoy the rest of your
Have a
Saturday.
great
Love
time.
you all. Take care. Stay
You
safe.
too. Cool.
Bye.
Thank you. Bye.
Bye.